Hello students, welcome to chapter 17, nutrition care. So in this chapter we are going to start with the therapeutic process, okay? Setting and focus of care. Individuals may seek and receive nutrition support in a private setting, outpatient facility, hospital, long-term care facility, rehabilitation center, public health community setting, or at home. In all these settings, the nutrition care will be different, okay? In some settings will be managed, support by other healthcare providers and staff members, or maybe if it's at home, it's going to be family members, right, taking care of the patient. The ultimate goal of nutrition support is to establish energy and nutrients balance according to specific needs of the individual. So always remember that energy is related to the caloric intake, and the caloric intake prescription by the registered dietitian is going to be based on the energy needs, right, of the patient. So clients need personal advocates. Healthcare providers such as the nurse, the dietitian can provide essential support and personalized care for these clients. Nutrition support can range from help with balanced daily meal plans to providing nutrition therapy through intravenous feedings. I want to mention something very important. Believe it or not, medical doctors only have, okay, 1 hour semester, maybe 1 week of nutritional therapy education. Doctors. That's why nutritionists are so important. Basically, your doctor, when you go to a meeting, is going to tell you if you have hypertension, you have to eat less food, less sodium, right? Period. It's not going to go in detail. They don't know, okay? Nutritionists are very important. The second line in education in nutrition are the nurses. You are receiving education in this nursing program, okay? It's 15 weeks, it's 15 hours. Even though I strongly believe it's not enough, okay? That's going to change little by little. Right now, that's why the system, there are very popular positions called health coaches that are basically giving you support and advice in all your nutritional needs. Functional medicine, the certification by the Cleveland Clinic, is all about nutrition. That was the hardest exam I took, because it's not only nutrition, but it's also the pathophysiology, the biochemistry. It's very hard. It's even harder than nursing. Okay, so what I said, you as the nurse is going to be handling information that the doctors do not know. So that's why you must master your information, okay? Nutrition support can range from health with balanced daily meal plans to providing nutrition therapy throughout intravenous feeding. In that figure that we're going to see demonstrate the nutritional care process model, in which personal interactions define the relationship between the client, the nutrition professional, and the client's care plan. So that's the relationship: client, nutrition professional, and the care plan. Healthcare team in the area of nutrition care, the RDN, also known as registered dietitian, carries the major responsibility of medical nutrition therapy. Okay, they are our bosses. They assess, they planify, they structure a care plan, and we just need to support that. We need just to make it happen. All of the healthcare team members, nurses, are in the closest continuous contact with hospitalized clients and their families. Such a connection is important to ensure the most beneficial healthcare approach and timely response to changing client needs. So in this diagram, we can see the nutrition care process model, right? Phase 1 is nutrition assessment and reassessment, obtaining and collecting important and relevant data, analyze, interpret collated data. And then in stage 2, we are going to do the diagnosis, identify the problem, determine etiology and stated signs and symptoms. That is known as the PES. Okay, the problem, the etiology, and the signs and symptoms. In stage 3, the nutrition intervention, determine intervention and prescription, formulate goals, and determine action, implement action. Okay, so you have the assessment, diagnosis, intervention. Then you have the nutrition monitoring and evaluation. Select or identify quality indicators, monitor and evaluate resolution and diagnosis. Okay, and this is all framed under the collaboration, skills and competencies, communication, evidence-based practice, critical thinking, documentation, code of ethics. Okay, and also we have to consider the practice setting, as I mentioned before, the economics of the patient, the healthcare system, and the social systems. Okay, so this is our nutrition care process model. What are the qualifications of a registered dietitian nutritionist? I am reviewing this due to the amount, since I'm working at a gastroenterology clinic and I also inform and treat patients based on the functional medicine approach. And also they know there is a connection between the gut and the brain, okay, gastrointestinal and the brain. Patients that are having disorders in the gastrointestinal, probably they are going to have a second condition in the mental state, depression, patients with inflammation in the gut, they present with depression, anxiety. So it's very important when you see somebody with constipation, diarrhea, this and that, then you have to think about, or maybe electrolyte imbalances, or maybe iron deficiency, anemia. You need to think how is that affecting the brain, and vice versa. Okay, so I came across many people that are interested in becoming registered dietitian nutritionist or health coaches, right, which are nurses that has a degree in nutrition and a certification in nutrition. So if you are really interested, we need you in the market. We need you. Okay, we need to reinforce, okay, this nutritional education. So they earn a bachelor degree with coursework approach approved by the Academy of Nutrition and Dietetics Accreditation Counseling for Education, Nutrition, and Dietetics, ACND. They completed a accredited ACN END supervised practice internship, usually between 6 and 12 months. And I've seen them in the hospital. Typical internships are either combined with a bachelor or master's degree or a healthcare facility or community agency. Before, I used to work in a hematologic oncology clinic. I was working with cancer patients as a family nurse practitioner or oncologist, nurse practitioner. And my right hand was the nutritionist. Okay, and we used to also work, team up with nutritionists students that were ready for graduation, right? They were doing their internship. After completing the requirements, a potential RDN, okay, must pass a national board examination administered by the Commission of Dietetic Registration. So it's not a 1-week course. Okay, they are certified. They need to pass an exam, like you pass the NCLEX. They need to pass an exam as well. Must get professionally current by completing 75 hours of approved continuing educational requirements on a 5-year cycle. Like we nurses, we need to complete our infection control studies every 4 years to renew our license, or nurse practitioners, we need to complete a certain amount of hours to keep renewing our nurse practitioner certification. Okay, some RDN also hold additional certification in specialized areas of practice, such as pediatric, renal nutrition, diabetes, weight management, and sport nutrition. In my case, I met the ones that are specialized in oncology nutrition, okay, cancer, for cancer patients. The RDN or RD, if preferred credential, is a legally protected title. Okay, so since you enter the healthcare field, no matter what specialty you have, what certification, you must continue your education. You have to update yourself. That's why I keep telling you, try to get the Medscape application so you can download information. You keep renewing and seeing the new trends, the new approved medication, therapies. You're going to be informed about the new research studies. It's free, okay? Physician and support staff. The team may include some of the following members: a nurse and dietitian, physical therapist, occupational, speech language, physiatrics, respiratory therapist, radiologist, physician assistant, kinesiotherapists, pharmacists, and social workers. The role of the nurse and the dietitian. Okay, let's make a difference. Let's make it clear. Okay, successful nutrition care plan specifically depends on the close collaboration of the dietitian and the nurse and the client. So the three of them is a triangle, right? The nurse, the dietitian, and the client. The dietitian determines the nutrition needs, plans and manage nutrition therapy, evaluates the plan of care, and documents results. That's the work of the dietitian. Throughout this entire process, the nurse helps to develop support. So we support. If the dietitian says the patient must eat 150 grams of protein per meal, this is just an example, okay? We are not challenging, questioning the orders, the recommendations. We are just there to support. We are providing emotional support. We have to educate the patients. It is important you get your 150 milligrams of grams of protein because this, and that, depending on the needs of the patient, right? We have to give the compassion and the care for the patient to achieve that goal. We have to report the dietitian, I did my best, but the patient is kind of having denture issues and he's eating only 75 grams. So you report, you support, but the decisions are being made by the nutritionist. A dietitian may only see a client once or twice during a hospital stay. Yes, because we don't have enough nutritionists in the system. Okay, and there is a lot of patients that needs nutrition, good nutrition. Usually in the hospital they prepare foods based on certain umbrella, right? If the patient needs ketogenic or more Mediterranean diet, this and that, but the nutrition is very individualized depending on the needs of the patient. So the dietitian may only see a client once or twice during a hospital stay, where the nurse will have constant contact with the client and will often be the person dealing with immediate nutrition related questions because of her frequent contact. And we also need to motivate our CNAs to support the goals of the dietitian. Okay, this is the hardest part because sometimes the CNAs, they don't have proper education and they are saturated with a lot of patients that they need to care of. I understand that, but we need to keep going and pushing and motivating. If the CNA does not have time, you, the nurse, you need to do it. The nurse process is a specific process by which nurses deliver care to clients and includes the following steps: assessment, diagnosis, planning, implementation, and evaluation. The nursing diagnosis is the nurse clinical judgment about a client's response to actual or potential healthcare condition and needs. Okay. A nursing diagnosis may include several issues like diarrhea, nutrition, failure to thrive, and fluid volume deficit. Okay, so we need to inform the dietitian about this. Coordinators and advocates. For example, malnutrition is common in hospital settings and there are many factors involved like pain or medicine-induced anorexia, surgery, emotional or psychological distress, or maybe when the patient gets pain medication, feels constipated, right? So you don't want to eat and that causes malnutrition. The nurse may be able to help resolve such conflicts by coordinating specific meals or meal delivery times with consideration for the client's wishes and scheduled procedures. Interpreters. The nurse can help to reduce the client's anxiety with the use of careful, brief, and easy understood explanations about various treatments and plans of care, reinforcement of prescribed therapeutic diet, and the result food choices to sustain compliance. So I'm going to be very clear on this. I know we have shortage of nurses, and I know that time is an issue. But this is always my mantra. You will keep listening this from me. Patient safety first. Safety is not only referred to avoid fall during hospitalization, or avoid the wrong medication at the wrong time at the wrong site, Patient safety refers to the safe nutritional patterns to avoid malnutrition. So you have patient safety first, do your job, and protect your license. I don't care you have to go home. If you haven't completed your task, you didn't call the interpreter to educate the patient, you are putting the nutritional needs of the patient in jeopardy. It's your job, okay? Your job is not going there to get 1 hour break and to leave at the time. You're supposed to do that based on staffing, right? But patient safety is first. You are taking care of a life of somebody else. And believe me, karma exists. So next time, it's not going to be a patient. It's going to be one of your family members being care of one of the nurses who is in a rush all the time. Okay? I'm just letting you know up front. A nurse can usually help answer questions about a client's nutritional plan, but if that is not the best option, the nurse can also refer to client to a dietitian for additional explanation. Teachers and counselors, basically, they are going to reinforce the information and the nutritional care plan. Phases of the care process. The Academy of Nutrition and Dietetics has developed a standardized nutrition care process for registered dietitian nutritionists. Okay, the nutrition care process is a systematic method that nutrition and dietetics practitioners use to provide nutritional care. It is composed by the following 4 steps: assessment, diagnosis, intervention, monitor, and evaluation. That's the one we saw in the graphic, right? Nutrition assessment. The purpose of the nutrition assessment step is to collect, classify, and synthesize as much information as possible. We can get help from family and medical history questionnaires. We need to gather information about the client's nutrition status, food habits, and living situation. Also, we can use the medical chart, oral or written communication with hospital staff. The following sections describe each of the 5 categories of data collected during the nutrition assessment phase of the nutrition care process, which is the following: food and nutrition related history, anthropometrics, I'm going to explain further this, biochemical data, medical tests and procedures, nutrition-focused physical findings, and client history. So food and nutrition related history, we are under the nutrition assessment umbrella of the nutritional care process. Nutritional care process is the big umbrella. We are in step 1, the assessment. And under assessment, we are in the food and nutrition related history. The clinical application box entitled Nutrition History, Activity Associated Food Pattern of a Typical Day, shows an example of a general guide of gathering nutritional history. Sometimes the dietitian will use a 3-day and sometimes longer food record to obtain a more specific food history. That's what I use in my clinic. I ask always the patient, I need your 3-day food diary, right? What you got for lunch, breakfast, lunch, and dinner, including snacks. Okay, this involves clients recording everything that they ate and the amounts and methods of preparation for 3 full days. Now, clients often do not volunteer information regarding dietary supplements intakes, and this is the part that is especially important. So if the client does not provide, which happens all the time, that is good to know. So for example, when the client in my clinic is going to go through colonoscopy, let's say, this is just to give you an example how people, they don't deliver, they don't share with you information. When they are going through colonoscopy, we always tell them, please hold your warfarin, your anticoagulants, or medications that causes bleeding like aspirin or NSAIDs for 7 days before the procedure. Okay. And then, because I am in functional medicine field and I know other herbs and supplements, I start asking directly, are you taking turmeric? Are you taking garlic supplements, right? For example, omega-3, okay? Because these can cause bleeding. So I tell them, I want you to stop taking these 7 days before. Just an example. And they say, no, oh yes, I'm taking turmeric. Oh yes, I'm taking omega-3. Okay? So these questions are not asked by the medical team because they are not familiarized with this. The nutritionists, yes, they are familiarized. I don't have a nutritionist in the gastrointestinal clinic seeing the patients at the same time that I am, following the appointment. So because I am trained on this, I can ask these questions. You as a nurse, you need to be informed. Okay, take all the courses you can related to supplements, and supplements are gonna be a huge part in your NCLEX. I'm telling you up front. So you need to ask direct questions about supplements, vitamins, mineral, multivitamin, mineral combination. Herbs are more likely to yield accurate answers and to provide insight into overall nutrient consumption. Physical activity logs are similar to dietary intake logs in that a client records all activity throughout the day in an effort to calculate energy expenditure. Similar to diet logs, physical activity questionnaires tend to be inaccurate and overestimate actual energy expenditure. It's not the same. I walk for 30 minutes on a very calm, pace, that I walk 30 minutes and I completed, let's say, 1.5 miles. That means that in 30 minutes, the patient is walking very fast. It's not the same. They can tell you, yes, I do 30 minutes every day, but there is a difference between the rhythm of one and the rhythm of the second patient. Less objective measurement tools as speedometers, accelerometers, motion sensors, and heart rate monitors may predict energy expenditure more accurately than questionnaires. Okay, so here is an example of a food pattern of a typical day. They can describe all the items that are listed here. And then you have strengths and limitation of techniques used to measure dietary intake. So you have here the 24 food recall. The strength is it's fast, inexpensive, and easy to administer, and can provide detailed information about the type of foods consumed. So this is the sad face, because these 24-hour food recall, one 24-hour recall cannot illustrate typical dietary intake, because that only for 1 day. So you really don't have plenty of information. The multiple day food record requires high degree of cooperation, and client must be literate and able to write. That's another factor. If the client cannot do it, they need somebody else to do it for him or for her. It takes more time to obtain data. Okay, does not rely on memory because the participants record intake immediately after consumption. So, and that's something that it has to be in reality, right? Some people, they go for lunch, right? And they are having companion and they get engaged in a very nice conversation. They forgot to document whatever they are eating. I'll do it later. Okay, so you need to be consistent in giving the instructions to the patient to complete the task. Food frequency questionnaire. This is extremely important. Cultural, ethnic, specific foods are often not included. So sometimes the patient does not tell you that is taking turmeric, right? That could be causing bleeding. Turmeric or curcumin. Sometimes the patient is telling you he is from a Hindu background, okay? So they are not eating a lot of protein, they are vegetarian. And you need to ask them directly, where are you from? What are the foods you typically eat? They are eating a lot of food high in grains, right? And they are gaining weight because the grains and the carbs are putting together sometimes, which is not a balanced diet. So you need to ask things directly. Sometimes you could be making mistakes, so you need to ask for authorization. May I ask you what culture, ethnicity are you from, right? Don't tell the patient, are you Jewish? Are you Russian? Are you Latino? You never know. You cannot be prejudgmental. Ask first in a very polite and kind way, okay? So you can start elaborating your report, your assessment. Diet history usually is assess usual nutrient intake and detect seasonal changes, okay? Then the dietary supplement use include vitamins, minerals, amino acids, fatty acids, herbs, botanicals, and other substances that have physiologic effects in the body. So here comes this patient from Mexico that is having cholesterol, hypertension, and diabetes issues in the first meeting. And then the dietitian, the RDN, is elaborating a care plan. And it happens that the patient is taking certain medications to reduce the blood pressure, hypertension, right? And then you didn't know that the patient is drinking a huge amount of water of Jamaica. That's the name of one of the flowers that is excellent to reduce the blood pressure, right? So you have two factors. You have the flowers of Jamaica and the patient is taking hypertension medications. So you want to avoid hypotension. You need to consider this fact in the plan. Probably the nutritionist is going to inform the doctor, probably we need to follow up this patient more carefully every 2 or 3 months to see what is the effect of this juice of in comparison or in parallel with the use of hypertension medications, right? So that those are things that we need to consider. Um, okay. The use of complementary and alternative medicine, CAM, such as vitamin, mineral, and herbal supplement use, is popular in the United States. Okay. Another thing we need to consider are the nutrients intake from food combined with high doses of micronutrients from supplements and from fortified foods and beverages may result in a habitual intake above the upper tolerant limit for many vitamins and minerals. Okay, so we need to be familiarized. The patient is taking, for example, metformin, and we know metformin reduces the B12 amount in the body. This is just an example between medication and the nutrients, right? So we have to take everything into consideration. Only half 53% of complementary and alternative medicine users report their use to their primary healthcare provider, right? They don't want to share. Yes, there are providers that they make fun. They don't believe in the powerful effects of some herbals, some mineral, vitamins, supplements, whatever, and they just reject this information. They just follow their medication protocols. But you need to invite the patient to still inform the primary healthcare provider. That way, they will be forced to learn about this. Okay, it's very important. I went to my gastroenterology and I told him I need a vitamin and mineral checkup because I didn't know the cashew nuts are high in selenium, and selenium works with zinc in a inverse way. If you have high selenium, the zinc is going to be low. If you don't need that much selenium, the calcium is going to be high. So I asked him and he said, why do you need this test? Because I am eating cashew nuts, and he was not aware of this. Okay, I love cashew nuts. So when they did the evaluation, the blood work, effectively I was having high selenium, and that causes diarrhea, feeling of nausea, and I thought this is the consequence of that much cashew I'm eating. So I'm telling you, you need to explain the doctor not only you want to do certain tests, but you need to explain why, and you need to show the doctor the evidence so they get educated as well. Okay, all providers anthropometric measures, so providers responsible for taking anthropometric measurements should practice taking correct measurements to avoid errors. Okay, you need to check for height, weight, body mass index are the most common anthropometric measurement. The RDN may take body composition and waist circumference measurements as well. Body composition, especially waist circumference, is going to tell you if a patient is having metabolic syndrome, right? For example, the patient is having high blood glucose, hyperglycemia, or is diabetic, and the patient is having low levels of HDL, which is your happy cholesterol, and the patient that is having also high triglycerides, and the patient is having big distended abdomen and high blood pressure, right there with those 5 conditions, you have a metabolic syndrome, meaning that you are not metabolizing properly the nutrients. Okay, and you are in risk for developing other conditions. So high sugar, high triglycerides, distended abdomen, high blood pressure and low HDL, your good cholesterol, puts you immediately in metabolic syndrome. That's why it's important to go to the PCP and follow and do your checkup. Okay, weight and body mass index. For the weight, for example, you need to measure the patient at the same time with the same clothes after bowel movement, for example, always at the same time. Okay, that's good to know. That's NCLEX alert. In terms of BMI calculator, which is your body mass index, you have to be familiarized on the parameter, the normal parameters, right? So it's 18 to 24 is normal, above 25 to 30 is 29.9 is overweight, above 30 is obesity. And then you have morbid obesity, which is above 40. So by seeing a patient, taking the weight, the height, you can calculate. There are different calculators, right? Some facilities, they have their own calculators, applications, websites. But if you don't have, you can go to the National Health Institute and you can access the BMI calculator. They are going to ask you the height and weight. And you can see if you are obese, overweight, or you're having a normal BMI. Okay. Also, we need to consider that if a patient had rapid and intentional weight loss, particularly the elderly, is significantly associated with increased health risk and mortality. So health providers should refer the client who have lost, listen to this, 25% of their body weight in 1 month. So if a patient weight is 100, was 100, and right now is 5% less, which be 5 pounds less, right now is 95 in 1 month of an intentional weight loss, okay, or 10% of the body in an amount of time for a no reason. So right now he lost 10 pounds. It's unintentional. The patient was not on diet. So now we need to think about it. We need to refer this patient for evaluation. Okay, 5% in 1 month or 10% in a certain period of time, and the weight loss is unintentional. I will also ask if you are bleeding somehow. Okay, because sometimes this is related to cancer in the gastrointestinal. So are you bleeding? That would be a kind of confirmation or giving you an extra hint of what's going on and where to refer this patient. If the answer is no, then you go, your urination is good. We are assessing the prostate, the urinary tract, we are assessing breast, right? And everything else. We are going to check the lymph nodes, okay, to see if the patient has any type of expression or swollen lymph node. Probably is a Hodgkin lymphoma. The patient is losing weight, and we are not going to see bleeding. We are not going to see any any symptoms in the gastrointestinal, but the lymph nodes in the neck, in the body, different lymph nodes are going to be swollen. Okay, so body composition and waist circumference is important. So we need to check for different methods to check for lean tissue compared with fat mass. And there are some methods like skin fold thickness measurement with calipers, hydrostatic weight, bioelectrical, blah, blah, blah. So I want you to see this video to see how the skin fold test is done to see the subcutaneous fat, okay? Let's watch this video first. Okay.
And place it at the base. First, we'll be showing you the 3 sites for women. The first site is the tricep. So if Katie could please turn around. Ask the client to hold their arm at a 90-degree angle, and then measure in centimeters from the acromion process down to the elbow. Katie is 35 centimeters long, and you want to make a mark at the halfway point. Now this is a vertical test, so you want to make your line vertical and then cross it horizontally to mark your spot of testing. Go ahead and relax. And our second test site will be the abdominal. Again, measuring in centimeters, and on the same side of the body, you want to mark 2 centimeters out from the belly button. The last site of testing is the suprailiac. You'll find the natural line of the iliac bone and go just superior to that and make a line in the direction of the bone, so it's a diagonal test. Now for the actual testing, you want to make sure your client is relaxed. Wherever you made your marking, you're going to pull the skin out just a little. Try and separating the fat from the muscle. Take the skin caliper and place it at the base of what you pulled out. Let it sit for a second before you take your reading. The number's on the dial, and then press the button and take it away. Next, you'll ask the client to turn around and continue on the next 2 sites. Again, a couple pinches, pull the skin out, open the caliper, place it at the base, take your reading, open it again, and take it away from the client. They'll do each site 3 times, rotating between the 3. Make sure you don't do all 3 at one site at one time. Again, the 3 testing sites on women is the tricep, the abdominal, and the suprailiac.
Perfect. Thank you so much. It was excellent. So you know how the skin fold thickness measurement with caliper test is done, and is one of the most common to identify the subcutaneous tissue. So here you have alternative measures for non-ambulatory clients. You have the total arm span, the knee high, recumbent bed length, okay, segmental height measurement, and then there are other tests called impedance analysis, the dual energy X-ray absorptiometry, and the body part composition tracking system. Mid-arm muscle circumference and triceps skin fold are two easy and fast anthropometric measurements frequently used in clinical settings for assessing body composition changes, right? So here is your dual X-ray absorptiometry that I want you to be familiarized with also. I'm providing these videos for you to understand better the concept.
Dual energy X-ray absorptiometry, DEXA, measures bone, muscle, and body fat present in the region scanned. The densitometer utilizes two thin beams of very low-dose X-rays with distinct energy peaks. These are absorbed by bone and soft tissue, allowing the calculation of bone mineral content. This content is divided by the area of bone being scanned to calculate BMD. The machine software utilizes BMD information to calculate T-scores and Z-scores. To derive T-scores, BMD is compared with that of sex-matched average 30-year-olds in a reference population.
Thank you so much. So this DEXA is basically used more often for the diagnosis of osteoporosis, right? But if you can see, also is going to check for fat components, but it's not used as much because the test is very expensive. So it's used more for the osteoporosis prevention. BMI and body composition measurements indicate the risk for overweight and obesity. We spoke about that. And but they do not evaluate where excess fat is stored. That's why you do the skin fold test, okay? The location of body fat is an important factor in nutrition assessment because not all body fat carries the same risk. Hello, this is a very important piece of information. Not all body fats carries the same risk. And I'm going to speak about this in a few minutes, in a few seconds. Individuals who store body fat in the abdominal region have significantly more health risks than their counterparts on the same weight who store fat in the hip and thigh regions. So, with postmenopause patients, I would say since the perimenopause, menopause, and postmenopause, we usually have the ovaries releasing estrogen, right? But when we are entering this phase, perimenopause, menopause, and postmenopause, the ovaries are not working, so the estrogen is not enough. It's not released by the ovaries. Now we need estrogen. So now the estrogen is going to be released by the adipose tissue in the abdominal area. That estrogen coming from the abdominal area is the bad estrogen. That's the one that causes cancer. Okay, I know this. I've worked with an oncology clinic and I've worked with breast cancer survivors. Many breast cancer patients are having high estrogen due to adiposity, due to fat tissue issues. Okay, so the recommendation is to lose weight. It's very important to exercise and lose weight in order to prevent this bad estrogen coming from the adipose tissue. Okay, for lower health risk, waist circumference should be less than 102 for men and less than 88 centimeters for women, and even lower in some Asian populations. Waist circumference assessment and waist to height ratio are important consideration for both overweight and normal weight individuals because they indicate the risk for chronic diseases like type 2, cardiovascular hypertension, certain types of cancer, overall mortality, even among individuals and normal weight. So the way I assess my patients, I enter the patient's room and immediately I focus my vision in the abdominal area. If the patient is having distended abdomen, immediately I know they are having diabetes, hypertension, cardiovascular, blah, 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 blah. Okay, so that you're gonna get to that level with more practice. Okay, so whenever you enter the patient room, you can assess by visualizing what's going on, the physical condition, what is immediately, right? The possible diagnosis. Biochemical data, medical tests and procedures. Laboratory data and radiographic tests may be helpful in assessing a client nutrition status. So we need to BOIN, nitrogen and serum electrolytes to evaluate renal function, your CBC to evaluate for anemia, creatinine, high index, evaluate protein, tissue breakdown. So this is important if you see a patient with edema. We need high protein intake. And protein is the magneto that absorbs the extra fluid. So we are going to check for creatinine and also albumin, okay? Fasting glucose, evaluate for hypo or hyperglycemia, lipid profile, for lipoprotein levels, liver enzymes, evaluate for liver function, right? Especially if the patient is obesity or overweight, we need to know if there is fatty tissue there, fatty liver. Okay, plasma, and if the patient is having fatty liver, we immediately need to suggest the patient to avoid acetaminophen or Tylenol, right? Plasma protein, serum albumin and prealbumin indicate protein status, as I mentioned before. Total lymphocyte count evaluate immune function, and this is important, good to know, because the immune system is everything in our elderly population. That's the biggest weapon they have to fight any type of infection. Urinary urea nitrogen excretion, estimate nitrogen balance. So hydration status is important. The presence of chronic illnesses, hydration is so important. So the patient can remove toxins by sweating, by urination, or by feces. Dr. Matalana, what's the relation between hydration and feces? So if your colon is not well hydrated, you are going to be constipated, period. Okay. Gastrointestinal function, also medical procedures are also useful to evaluate function, disease, and malfunction, along with gastrointestinal tract disturbances like peptic ulcers, skeletal system integrity. Several tests can assess for risk of osteopenia or osteoporosis. We saw the DEXA. Here it is, the dual energy and X-ray absorptiometry. Resting metabolic rate, evaluating a client's resting metabolic rate helps to establish total energy needs. Okay. How to test for metabolic rate. Here is another video that you have to consider. Guys, I love to give you all the information. You don't have to do extra work. I'm doing it for you. Okay, so enjoy.
For the review to accurately measure the resting metabolic rate, or RMR, the patient needs to be in a true resting state. It is important that they be allowed to sit, recline, or lie down while testing. Your designated testing area should be free from noise and distractions. Best results are achieved when testing is performed 4 hours after food consumption, when stimulants have been avoided, and prior to exercise. It is recommended that the test be performed by your office medical assistant. The clinician can then review the test results with each patient. Operating the review is incredibly easy. Once turned on, it runs through a self-calibration cycle. Make sure that no filter or metabreather is covering the intake port during this cycle. When the unit indicates calibration complete, simply extend the metabreather tubing and have the patient make a nice seal around the mouthpiece. Put on the nose clip to ensure that all the air breathed out is analyzed by the review. Let the patient know that if they need to remove the metabreather once or twice during the test to swallow or moisten their lips, it won't affect the accuracy of the test. Data from erratic breathing must be discarded, so the sooner a patient reaches a relaxed, steady state, the shorter the test. The average length is 10 minutes, but it can take longer for patients who struggle to relax. When the test is complete, the review will beep. You simply dispose of the metabreather mouthpiece, enter in some basic data, and the results are ready to print. You will then be able to customize your patient's calorie goal depending on where they are in the weight loss process. That's metabolic testing with the review. It's quick, easy, and anybody in the office can do it.
Thank you so much. So that's why there are some patients that come to me, Doctor, I'm eating very healthy, but somehow I am not losing weight. Yes, because your metabolic rate, the resting metabolic rate, is not working properly. You're supposed to, have a metabolism that works perfectly when you are resting. Okay? Yes, you are learning. I hope you're learning some stuff. Some of the clinics, they are not doing this. You probably will need to go to functional medicine specialist or a very good nutritionist that can help you with these examinations, or you can request, where can I go for this specific test? I need to see how is my metabolism working. Nutritional focus, physical findings. Be careful. Observation of various areas of the client's body may reveal signs for poor nutrition. Provides example of clinical signs relevant to a client nutrition status. Okay, so here is a very good table. I love this table. For example, I highlight in yellow the major areas. So for hair, you have to check your deficiency in biotin, for example, which is your B7. I want you to focus on how often the B vitamins are very important here. Probably excess of vitamin A. That's why it's important to get a full checkup on minerals and vitamins. So you do not prescribe yourself the vitamins you believe are needed unless you have evidence in your laboratory results, right? So you are having hair loss because you have been getting a lot of vitamin A. Head and neck, you are having deficiencies in, for example, you are bleeding, you have deficiencies in vitamin K, or maybe an excess if you're having headache, excess in vitamin A and D. Oh, wow, I didn't know that. In the eyes, maybe you develop blue sclerae. Okay, what is blue sclerae? Look at this picture. It's not a video, even though I select videos that are very short. Look at this picture. I hope you can see it. This is the National Library of Medicine. You see the sclerae here is blue. Okay, what is happening? So probably you have a deficiency in iron. Okay, now the mouth, maybe you have a deficiency in niacin, which is B7, another B7. Maybe you're having glossitis, which is red sore tongue, okay, or it's a deficiency in B9, which is your folate, or B12. So you see, all the B's vitamins are very important, but you need to have a test to know which one is the one that is causing problems. In the skin, for example, you have petechiae or ecchymosis. Probably the deficiency is on vitamin C or vitamin K, right? Now let's go to the nails, okay? Maybe you have a spoon-shaped nail. That's a deficiency in iron, okay? Or maybe there are some side effects of your manicure. You are putting your powder manicure, your fake nails, and this is causing a problem in your nails. Now the heart, you have an enlargement, suddenly you are developing tachycardia. Maybe you're having deficiency in B1, the thiamine. Maybe you're having sudden failure or death, somebody in your family, okay? Deficiency of potassium, of selenium, or maybe excessive potassium. Now you're having hypertension. We know excess in sodium. Maybe you're having problems in the liver. You have ascites, which is edema. You're having deficiency in protein. Musculoskeletal extremities, half tenderness. Okay, especially nurses, this section is very important. You're gonna work standing long hours. So your thiamine, your vitamin C, biotin, and selenium must be in good standing. Your knees, vitamin D, calcium, phosphorus, copper. Okay, but also you need to check this on your seniors. Okay, you need to propose to the doctor, can we check vitamins and minerals to see how we can address nutritionally these deficiencies. Okay, neurologic, this is so important. You have paresthesias because of lack of vitamin. All B vitamins are so important and must be in good standing, okay, because they are going to cause neurological, musculoskeletal issues, okay, tremors due to deficiency in magnesium, drowsiness and lethargy, thiamine, your vitamin D, or maybe an excess in vitamin A and D, depression, depression, anxiety, please let me check my thiamine, B12, and biotin, okay. Client history, we need to ask questions directly, ask for alternative medicines, supplement, always ask with permission about religion, culture, family interactions, okay. And we need to, if the doctor forgot to do this, you need to reinforce that assessment. Also try to figure out psychological and emotional problems. So if I have a patient that is coming with irritable bowel syndrome, and we know the connection between the gastrointestinal and the brain, irritable bowel syndrome is a condition in which the patient is going to develop either constipation or diarrhea, and is highly related to the mental state, okay, highly related. So if you have a patient that is a nursing student with constant diarrhea, now I'm going to check the vitamin B12, thiamine, and biotin. Let's see if that depression, anxiety correlates with the irritable bowel syndrome, okay? Now, in patients that are elderly and they are in healthcare facility, they are depressed because the family is not next to them. So they are going to feel with depression, and sometimes they don't want to eat. So malnutrition is going to occur. Let's check for this laboratory, these micronutrients, minerals, and supplements, right? Probably they need something. Nutrition diagnosis, we need to identify and labeling of an existing nutrition problem that the nutrition and dietetics professional is responsible for treating. So in that diagnosis, based on the findings, you need to mention the intake, how much is the client consuming relative to their needs, the clinical, what nutrition problems may the client have, behavioral, and environmental. And in order to elaborate a diagnosis, you need three pieces. You need your problem, okay, iron deficiency anemia, you need your etiology, okay, and always you're going to be using the word related to so iron deficiency anemia, related to, for example, related to lack of consumption of protein, for example, right? And signs and symptoms, you are going to use the words as evidenced by. So iron deficiency anemia related to, right, poor consumption of protein as evidenced by, right, low RBCs, low hemoglobin. You can cite your laboratory or your physical symptoms, okay? This is just an example to understand how the diagnosis is going to be done. Nutrition evaluation, so you need to purposefully plan actions designed with the intent of changing a nutrition-related behavior, risk factor, environmental condition, or aspect of health status. The goal is to resolve the nutrition-related etiology and diagnosis. So there is a collaboration between the nurse, the patient, and the RDN, and the categories addressed during the nutritional intervention phase of the nutrition care process are going to be food and nutrient delivery, nutrition education and counseling, coordination, and nutritional care. So food and nutrition delivery, we are under the umbrella, right, of the nutrition intervention, which is part of the care plan, okay? Food and nutrient delivery, personal adaptation, we need to consider and explore, we need to explore the recommendations and follow really the recommendation of the RDN in the following areas: the personal needs, the diagnosis, the nutritional therapy, and the food plan, okay? So if the RDN forgot, you see in the care plan that something is missing, you can provide extra information so the RDN can elaborate a better plan. Mode of feeding, okay? The following three components demonstrate common modifications to the oral diet. The energy is very important, an increase or decrease in total energy value of the diet expressed in kilocalories. So depending on the energy, if a patient is in bed, right, and doesn't feel like moving, probably the calories must be changed. Nutrients, modification in amount of form, the one, two, or more of the essential nutrients. And also the texture, modification to the texture or seasoning of the diet, right? In the event that nutrients needs are not adequately satisfied through oral intake, the RDN will explore other methods of delivering the food. So enteral feeding, we know that enteral feeding, okay, administered by a tube, makes use of the digestion and absorption functions of the gastrointestinal at some point below the mouth. So when we use enteral, we don't use the mouth. We use a tube that is connected at some point below the mouth. Exact placement of the feeding depends on the point within the gastrointestinal tract tolerate introduction of food or nutrients, okay? And the tube may pass through the nasal cavity down the esophagus to the stomach or small intestine for short-term feedings. If we are talking about parental nutrition is administered intravenously and carries risk associated with invasive nature, right? And it's very high in carbs and glucose, okay? Now, nutrition education and counseling. This is a one-to-one experience with the dietitian or may occur in a group setting. Initial education and counseling interactions during inpatient stays can continue throughout patient appointments when necessary. Okay, so we need to establish a long-term plan to make such changes that are commitment to the education, counseling, and both professional and personal support. Coordination of care, for example, if we are going to continue with the enteral tube feedings, require the coordination of dietitian, nurse, prescribing physician, and the clinical pharmacist. Interdisciplinary connections within the healthcare make the connection of nutrition and make it possible and more effective. Now, nutrition monitoring and evaluation. This is the fourth step of the nutritional care process. Remember, we are analyzing each step of the nutrition care process. Right now, we are in the monitoring, right, and the evaluation. So the RDN identifies their progress toward their goals. The three components of this process are monitoring progress, measure outcomes, and evaluate outcomes. So in this nutritional care process, they are going to check the same categories as the nutritional assessment categories. So they are comparing the assessment versus the monitoring and the evaluation. They are comparing the food and nutrition related history, the anthropometric measurement, where we start, how we started this, and where we are now. Biochemical data and nutrition focused physical findings. Okay, so for example, the goal for a client is to consume 74 grams of high biologic protein per day through enteral feeding, then measuring body weight change that not reflect progress toward meeting the identified goal, right? So rather, analyzing feeding schedules and enteral formula delivery records in the client's medical chart. That's where the nurse is going to take place, right? That's the participation of the nurse. Would be a more appropriate method of evaluating the client's progress towards meeting their goal. Excellent. Diet-drug interaction. This is a very important part in this chapter. So know that you may see diet-drug interaction expressed in several ways, such as drug-diet interaction, food-medication interaction, drug-nutrient interaction. Okay, polypharmacy is going to be very common in elderly clients. Majority is taking at least 1 to 2 medications and multiple prescriptions in other cases when they are over the age of 65. And SAC reactions, there is multiple reactions, right, because of these medications, can vary depending on normal dietary habits, nutritional status, disease type, severity, compliance. So gathering information is crucial, okay? And this is good to know. We need to gather all the information, especially from dietary supplements, as part of a complete assessment, okay? So diet-drug interaction are often categorized using the distinction listed below. So, for example, if we have a case, number 1, class 1, effect of obesity and malnutrition on drug action, for example, poor protein, albumin, lack of drug absorption. Remember that albumin is a magneto to absorb extra fluid, but also is a magneto to the good absorption of medication. So if the patient is taking medication to lose weight or for any cholesterol medication, if there is no good protein, that medication is not going to be absorbed. Now, class number 2, effect of nutrition on drug action. Nutrition, please take medication on fully empty stomach, for example, right? To be absorbed, or take this medication with food, okay? Class 3, effect of specific nutrients or dietary supplements on drug action. So this would be your vitamin K and warfarin, okay? That will cause an interaction. And number 4, effects of drugs on nutrition status. For example, your mirtazapine, you're going to see already, or maybe you saw already, this mirtazapine in the hospital, or you're going to see it. It's very popular. Is used for, is a tetracyclic antidepressant in hospital or in nursing home, but also is used to increase appetite, because the people is depressed, you need mirtazapine in order to treat that depression, so therefore they are going to feel like eating more. They are going to increase the appetite. This work on your serotonin and norepinephrine in your brain. Number 5, effects of drugs on nutrient status. So for example, your metformin on nutrient status, so that reduces your B12, right? So interactions in which food increases or decreases the effect of drug can adversely influence. So this affects the absorption, as for example, the lack of protein, the distribution, the metabolism, or elimination of a drug, right? So you have here this nice, this is important as well. A high-fat meal increases the absorption of some drugs that are lipophilic. Okay, there are some vitamins that are lipophilic. Your ADEC, that's my mnemonic. A, vitamin D, E, and K. They are lipophilic, ADEC, right? So you need to have high fat content when you get those vitamins, right? Here you have all the process, mechanism of drug nutrient interaction for you to analyze. And then also I want to clarify when we spoke about pharmacokinetic, okay? As I always mention, you need to be getting into the habit of break down the words and use your prefix and suffix, okay, so you can understand. Kinetics refers to involving or producing a movement. So pharmacokinetic is going to be the movement that is going to cause good absorption, distribution, metabolism, and excretion of the medication. Okay, so the interaction, for example, of grapefruit and several medications has been under critical evaluation for many years. You have also your vitamin K versus warfarin. You have also some other medications that interfere with the appetite because of change in taste or smell sensation, your amitriptyline, that is also a neurological medication, and your metronidazole, which is a type of medication used for the traveler's diarrhea. Okay, medication that stimulate the appetite, your antihistamines, your Benadryl, your steroids, and your mirtazapine, as I mentioned before. So you have the drug nutrient interactions. Taking medication along with over-the-counter vitamin and mineral supplements may result in deterioration drug nutrient interactions. So in the case of warfarin, right, if a patient is taking warfarin but also is taking turmeric, right, there is a counter interaction, right? Warfarin is going to avoid the bleeding, but then turmeric is going to cause the bleeding. So those are things that we need to double check, okay? Also, here is another nice case study that you can use for your own benefit to work on it. Drug herb interaction. Scientists have studied the herb interaction in most commonly taken herbs, such as St. John wort and ginkgo biloba. So I have provided a link here from the Mayo Clinic. I always like to provide very good evidence resources, right? Like, for example, your National Institute of Health, your Mayo Clinic, your Cleveland Clinic. Very nice resources, okay, that are reputable. Okay, so the Mayo Clinic, here is the link. You can access Mayo Clinic drugs, and you can type in the Mayo Clinic ginkgo biloba, and all these side effects, counter interactions, and contraindications are going to appear. Okay, so for example, medication groups that have documented adverse reaction when taking St. John's include anti-cancer medications. This is so important. We cannot skip this topic. Antihistamines, antimicrobial, those are your antibiotics. Bronchodilators, okay, that they have adverse reactions when you take the St. John's. Cardiovascular medications, here are your blood pressure medications, your corticosteroid hypoglycemic agents, your metformin, your glipizide, immunosuppressants, lipid lowering, you name it. Some experts recommend that clients avoid taking St. John's wort concurrently with any other over-the-counter or prescription medication, period, because the different type of interaction with multiple type of medication, that's why they prefer, you know what, don't take St. John's. Other commonly used herbs are involved in drug interaction, like ginkgo biloba or ginger or ginseng and garlic. Those are the other ones that I also keep an extra eye. Okay, ginger, blood thinner, might amplify the possibility of bleeding. Diabetic medications, also ginger can potentially lower blood sugar levels, which may heighten the risk for hypoglycemia. So you are having your diabetes medication, and also you are taking ginger, and on top of that you are adding cinnamon, that is causing also to lower your sugar levels. So all of them, woohoo! And then you are taking a very popular right now called berberine, which is excellent. It's a supplement, it's natural berberine to lower sugar, okay? But has to be prescribed by the functional medicine doctor, right? In order to reduce less consumption of other medications that treats diabetes. So then you take your, let's say, metformin, your glipizide, insulin, you put berberine, you put cinnamon, and also your ginger, forget about it. We can have a hypoglycemic event crisis on this patient. Potential drug-nutrient interaction with non-risk factors, your proton pump inhibitors, for example. These proton pump inhibitors are going to suppress the acid that your stomach produces. So when the acid is suppressed, the absorption of nutrients is going to be less. Okay. For example, we take this one when the patient is having H. pylori infection, or let's say if the patient is having low dietary intake, vegetarians, and on top of that, they are lacking the nutrients already, but on top of that, they are taking the proton pump inhibitors. The problem is going to be a deficiency in B12, vitamin C, iron, calcium, you name it. Now, if a patient is taking aspirin, right, which is a non-steroidal, we are going to be lacking on vitamin C and iron, okay? We know that aspirin, besides being a non-steroidal, also is it works on the platelet mechanism of action. And you have a long list here that you should be able to analyze. Your hypercholesterol medication, right? Your statins. The problem is statins are related to myopathy, which is muscle pain, okay? So you have to be familiarized with all this. You have corticosteroids, your bronchodilators, antidepressants, oral contraceptives, okay, are going to cause B12, B6, vitamin B12, folate, calcium, magnesium, vitamin C, and vitamin E to be having lack of nutrients, okay? And risk factors for these medications are vegetarian as well, right? So this is important. You have to analyze the cultural background of the patient. You have to check for the herbs, supplements, vitamins that the patient is taking. Look at this graphic. You have patients that during their younger years, they are not taking, or maybe taking one prescription medication. As they get older, you see 65, the curve is really going up, and there is a significant percentage of population taking at least one dietary supplement besides the medications, okay? So putting all together, I strongly suggest you to review your chapter review questions and to practice your next generation NCLEX examination style case study, because this is going to be the type of question you're going to have on NCLEX. Okay, so I'm doing it as I am preparing for your class, and you must be doing the same. Thank you so much. We conclude chapter 17, and with this we conclude the 2 chapters that are coming in week 2, the lectures of week 2. See you next time.